You're listening to Nursing Survival. Today's episode is about cholecystitis. Hey, future nurses, welcome to Nursing Survival. I'm Nurse Camille. If this is your first time listening, then thanks for coming. This podcast reviews all the important information about medical conditions specifically for nurses. This will help you in nursing school, for the NCLEX, as well as out in the real world. You can find the study guide that goes along with this episode on nursingsurvival.com. I have created several guides that can help you really understand the information. New episodes come out weekly, so add me to your favorites. You can also follow me on Twitter, Facebook, or Instagram. Let's start studying. Cholecystitis is inflammation or swelling of the gallbladder. It is most often caused by gallstones or caliculi blocking the cystic duct. The cystic duct is the channel between the gallbladder and the common bile duct. The gallbladder is responsible for releasing bile into the small intestines to break down fats. When the cystic duct becomes blocked, the bile builds up inside the gallbladder. Gallstones are created when bile lumps together and becomes solid. Cholecystitis is usually caused by a blockage of the cystic duct by a gallstone. It can also be caused by tumors or infections. Gallbladder sludge is thick liquid buildup of bile that can happen when a person loses weight quickly or during pregnancy. Gallbladder sludge can also block the release of bile, causing it to back up inside of the gallbladder. Another cause of cholecystitis is vasculitis, which is an inflammation of blood vessels. The damaged blood vessels decrease the blood flow to the gallbladder. Sluggishness in the gallbladder can also cause cholecystitis. Risk factors that can contribute to cholecystitis include pregnancy, diabetes, obesity, hormone contraceptives, and a high-fat, high-cholesterol diet. Losing weight quickly can also contribute. To diagnose cholecystitis, the patient may need to have a gallbladder ultrasound. It is a non-invasive procedure that allows the medical provider to see the organ. The patient usually needs to be NPO for 8 to 12 hours before the exam. Obesity and bowel gas can hinder the visibility of the gallbladder. The patient will be positioned either supine or in the left lateral cubus position. The liver may be used as a window to see the gallbladder. Computerized tomography, or CT scan, may also be done to visualize the gallbladder. A CT scan uses a combination of computer imaging and X-ray. It is useful for spotting ruptures or tears in the gallbladder wall as well as infections. It is not the most useful tool for visualizing gallstones. A magnetic resonance imaging, or MRI, is better for diagnosing stones. Percutaneous transhepatic cholangiography, or PTC, is a procedure for visualizing the biliary tract. A contrast is injected into the bile duct of the liver and X-rays are taken. It will allow the medical team to see the bile ducts and blockages. The blockages can be treated with a drain or a stent until a more permanent fix can be done. During the procedure, a needle is used to inject dye through the liver into the bile ducts. The patient will need to be NPO because anesthesia will be used. Inform the patient of risk from the procedure, including blood loss, infection, and organ damage. It should not be performed on a patient with liver disease or ascites. Use caution with the patient on anticoagulants. Another diagnostic procedure is an HIDA scan. It is used to see the production and movement of bile. It can help identify blockages and inflammation, but not gallstones. During the procedure, a radioactive dye is injected into an IV. Images are taken to see how the dye moves through the gallbladder. The images are taken over an extended period of time, usually around an hour to an hour and a half. The patient may need to come back 24 hours later for more imaging. The patient will need to be NPO before the procedure. The procedure is not recommended during pregnancy or if the patient is breastfeeding. Endoscopic retrograde cholangiopancreatography, or ERCP, is a procedure in which an endoscope is inserted into the throat and then goes through the stomach into the small intestines. It allows the medical team to find gallstones or blockages in the gallbladder. Images are taken with X-ray. The stones can then be removed during the test. The procedure is invasive and is normally done after non-invasive tests have been conducted. The patient will need to be NPO before the procedure. They will also be sedated. Use caution with patients who are on anticoagulants or are pregnant. Tell the patient they may have a sore throat for several days afterwards. Risks associated with the ERCP include hemorrhage, infection, perforation of the gallbladder, small intestines, or the ducts. The patient may have blood tests done, including a white blood cell count. If it is greater than 10,000, the patient probably has an infection, but obviously you can't tell where based on just that. Bilirubin is a substance made during the normal breakdown of red blood cells and is an orange-yellow color. It is normally processed in the liver and excreted out by the body. A high total bilirubin is greater than 1.5, and a high direct bilirubin is greater than 0.3. It may indicate that the gallbladder is involved. Amylase is an enzyme that helps with digestion. It may be elevated if the pancreatic duct, which allows amylase to enter the small intestines, is blocked by a gallstone or inflammation. An elevated level is greater than 180. Alkaline phosphatase, or ALP, is a digestive enzyme that is a sensitive indicator of gallbladder issues. A level greater than 140 is considered high. Sometimes the patient is asked to fast for 12 hours prior to the blood test. ALT and AST are liver enzymes that may be elevated as well. Elevated is usually greater than 35. Now we're moving on to signs and symptoms. The most common symptom of cholecystitis is biliary colic. It is right upper quadrant pain that can radiate to the back or the shoulders. It is often worse after eating, especially a fatty meal. The pain can be very intense and constant. Their abdomen may be tender to the touch. The patient may also experience nausea or vomiting, bloating, fevers, which is a temperature greater than 100.4 Fahrenheit or 38 degrees Celsius. The patient may appear to be jaundice, which is yellowing of the skin or eyes due to an increased bilirubin. Complications of cholecystitis include pancreatitis. It is an inflammation of the pancreas. Gallstones can obstruct the pancreatic duct, causing the pancreatic enzymes to back up into the pancreas. Another complication of cholecystitis is a gallbladder rupture or perforation. The patient may develop caliculi or gallstones, which can lead to further dysfunction of the gallbladder. If acute cholecystitis is left untreated, the inflammation and the infection can destroy the gallbladder tissue, leading to gangrene. Empyema or pus in the gallbladder can be life-threatening and lead to severe infection throughout the body. It can also lead to complications with other organs, such as the pancreas or the liver. Treatment of cholecystitis depends on whether it is caused by gallstones or other factors. An ERCP is the gold standard for treatment of gallstones. Remember that it is an endoscopic procedure that allows visualization of the gallstones and blockages. During the procedure, the gallstones can be removed. A cholecystectomy may be performed as well. It is the surgical removal of the gallbladder, and it can usually be done laparoscopically. Depending on the patient's symptoms and what the diagnostic procedures show, the patient may be placed on bowel rest. They'll be given IV fluids so they don't become dehydrated while they fast. Antibiotics are used to treat infection and are often given with bowel rest. Cholecystokinin stimulates the gallbladder to contract. It also causes the sphincter of the small intestines to relax. It helps to inhibit the formation of gallbladder sludge. Patient education includes diet modification. Encourage the patient to lower their fatty food intake as well as cholesterol. They may need to eat small, frequent meals. Obesity plays a factor in cholecystitis. Promote exercise. Inform your patient that weight loss should be done slowly. Rapid weight loss increases the risk of developing gallbladder issues. After a cholecystectomy, the patient may develop frequent loose, watery stools. Antidiuretic medicines may be recommended. Cholestyramine is a bile acid sequestrant that inhibits bile from being reabsorbed in the GI tract. It can interfere with fat digestion and the absorption of vitamins and other medications. They should also be informed of the risk of infection at lap sites. Tell them to contact the medical team if the sites become red, swollen, or painful, or if they have foul-smelling discharge. Thank you for listening to this episode of Nursing Survival. Find me at nursingsurvival.com for more study guides. I have fill-in-the-blank and even coloring page study guides. You can find me on Twitter, Facebook, or Instagram. I'd love to hear from you. Please send me any topics you'd like to hear. Thank you.